Donc, bonjour tout le monde. Je suis Danielle Gauvreau, directrice académique du CIQSS. Ça fait plaisir de vous souhaiter la bienvenue. Aujourd'hui, on a un auditoire qui est divisé en deux endroits. Donc, bienvenue aussi aux gens de Sherbrooke qui sont avec nous. Il nous fait plaisir d'accueillir Paul Peters qui vient nous présenter un séminaire qui s'intitule Geozones An, Area-Based Method for Analysis of Health Outcomes. Je parle en français parce que je sais qu'il comprend de toute façon, mais welcome and thank you for coming. And we are really looking for your presentation. Donc, pendant la présentation, si vous avez des questions, on utilise le micro pour la transmission avec les deux endroits. Simplement, évidemment, c'est pas pour la salle ici, donc c'est pour ça qu'on utilise les micros. Merci.
Thank you. Are we ready? Ready to go? Okay. Thank you very much for inviting me, first of all, to come and talk to both the people here present and the people virtually present via the line. The presentation I'll be talking about today is Geozones. It's an area-based method said for an analysis of health outcomes. I'm with Statistics Canada in the Division of Health Analysis Division. The presentation will be in English today with English slides, but my colleague, I have a colleague here, Dr. Philippe Finesse, also from Statistics Canada. And if you want to ask a question, and I can understand a fair bit of French, and he can respond, obviously, easily in French. So we can have a bilingual discussion if we would like afterwards. But in the meantime, I will present to you in English, and I hope I can figure out the technology as we go along here. There we go. So I want to give you a bit of an overview of this methodology. We're familiar with area-based methods, or what we call area-based methods. We use them a lot in social science research and in health research. And I want to talk to you about one method that we've investigated a lot at Statistics Canada, and we've been using to analyze specific subpopulations within Canada. And I wanted to go over the details of the methodology for you, and it's a very simple methodology, although it has some nuances which can be slightly complex, and I want to try and display those to you, and then rather than bore you too much with the statistics of it, which I really like data and statistics, being at Statistics Canada, it's not as interesting to discuss, so I will also give some examples with pretty pictures and maps to entertain people, and hopefully provide some information as well. Outside of academic research, there's been a larger push within the federal government and within federal government departments to focus on health inequalities rather than just on the provision of health, recognizing that there are differences in health and in health outcomes and health behaviors for different individuals within Canada. And this has been recognized for probably about the past 10 to 15 years at the federal government level with the federal, provincial, territorial ministers of health. 2010, there was a recognition that the health of the population is an important measure in contributing to overall well-being of society. So the health of all members of society is an important contributor to the overall members. This is, of course, repeated at the world level, where 2008 we have the social determinants of health. We have Michael Marmot, the Marmot Report, and then as well we had the Romano Commission, the Kirby Commission, etc., which reaffirmed these within the Canadian context. And of course, academics have been researching this and speaking about this for a long time, so this is nothing new. However, there are a lot of limitations in doing this in terms of analysis. How do we look at different subpopulations? When we're talking about health and health indicators, we're talking about things like life expectancy, hospitalization, mortality, basic core indicators. But how do we look at them by different subpopulations? Death certificates, cancer registries, or hospital records don't contain any individual information. They have a name, an address, health card number if it's within Canada and within the provinces, but they don't contain any other identities, ethnicity, Aboriginal identity. Quebec has maternal education a lot of the time, but again, there are some issues with that. But they're not uniform across the country. So if we want to really get a state of the health of the different population group in Canada, we need other methods to do this. So there's two primary methods that we use to do this. First is an area-based approach, and second is a record linkage approach. And Statistics Canada has been working in a lot of these, particularly in the record linkage area. StatsCan has a large program and is sort of one of the world leaders in linking records. And this is where we take the two different data sources, usually an administrative data source and a secondary source, such as tax information or the census, and we join them together based on common identifiers, usually name, age, sex, place of residence, marital status, and we link those two together, and we can have quite success. I'm talking next week at the Research Data Center Conference on one of our big linkages using the Canadian Census cohort. Today, I'll be talking at this research data center on the Geozones approach, which is an area-based approach, which has been used for a long time at Statistics Canada, particularly by researchers such as Russell Wilkins, to look at income gradients and income differentials for different health outcomes such as mortality, birth outcomes, cancer incidence, things like hospitalization rates. And we've expanded it recently to look at Inuit areas or Aboriginal areas or areas with different proportions of foreign-born or immigrants. Foreign-born includes permanent residents and immigrants. So we have both combined, and we call that foreign-born. Common to both of these methods is the use of administrative data. Wherever administrative data, we're talking about these additional registries used for such as vital statistic registries, cancer registries. They usually lack, as I mentioned before, information about the population, health-relevant determinants and individual characteristics. So we use area-based measures for doing this. Area-based measures are particularly strong in that they characterize the entire population under study. So in epidemiological research and in public policy research, or research geared towards providing information for policymakers, it characterizes the entire population within an area or a service provision area. So most services are generally provided on an area basis, whether it's within neighborhoods, we target specific neighborhoods, or we have specific health regions or health areas. So studying it by area-based is very useful. It also can produce consistent estimates over time because we can look at these over multiple periods. We can look at an area-based measures. We can look using things like the census. We can look at it for multiple decades through each census periods. And we begin to look at mortality across over time. And they can be tracked via geographic location, so we can look at differences in space as well. So in existing research, area-based measures have been shown to have consistent differences between income and other health outcomes, such as mortality, injury, life expectancy, etc. And this uses what we call gradients of neighborhood income levels. So we have low income, low medium, usually about a 5-point or a 3-point scale or something like that. So we have different gradients. We can also use it in a binary sort of area. We have an area that is characterized as something. So Aboriginal areas with a high proportion of Aboriginal peoples. So these are what we would call, high percent Aboriginal areas in Canada. Or we could use it as different gradients, but different in that income gradients has a clear gradient from lowest income to highest income in terms of neighborhood. Immigrant terciles is areas with proportion of immigrants. It's not so much of a ranking, it's just and you have differences between the two different areas. Rather than just having immigrant neighborhoods and non-immigrants, we show a difference between these three areas. But the goal is to look at the difference between them. And with that, we can look at hospitalization and the healthy immigrant effect. So the method I want to present today is a particular method which we have used to look at these different population subgroups. And the Geozones method refers to the construction of these area-based measures. So it's a method which is essentially borrowed from geography and from residential segregation analysis, which sits between geography and sociology, where we look at ethnic and racial segregation, depending upon the country, the language we use. And there's been a lot of research, particularly in the United States, looking at Black, white, Latino residential segregation, and in other countries, where we begin to look at other ethnicities and segregation. Less so in Canada. We haven't discussed that so much. We generally don't talk about racial differences as much within Canada. It's not as discussed, but we do look at different ethnic differences and different ethnic neighborhoods. It uses the census population as a foundation for it, because that gives us some most reliable estimates of population count. So it's done every 5 years. It it has a quite strong in that. It can be calculated at different levels of geography. So pretty much everyone's here is familiar with the StatsCan geography, which is sort of the de facto standard for Canada because it's the biggest geographical data set. So we can calculate it within small areas, city blocks, so dissemination blocks, dissemination areas, neighborhoods, what are called census tracts, or between cities, so more municipalities, census subdivisions, and larger, or small isolated areas such as Aboriginal communities, which are usually census subdivisions, or usually an individual subdivision. And these link to the health administrative data set, usually via postal code. So on the one hand, we have our denominator, which is our population at risk, population under study, our neighborhood population, which usually comes from the census. Can come from other sources, but it usually comes from the census. Aboriginal areas, it sometimes comes from the Aboriginal First Nation Register, the band or treaty, things like that. But the data that we use to analyze the numerators come from other sources. So these are often hospitalization records, 911 records, vital statistics, cancer records, and the geographic identifier that's usually on those is, if it doesn't already have a StatsCan geography, such as a DA or a CT coded on it, it's a postal code. And that DA or the CT that's on the file, if you have it, is usually coded from the postal code. So it's usually this postal code that's the linking point. I'm not going to get into the mechanics of that and the methodology in that. I'm sort of now doing a lot of work on postal code geocoding, but it's a fairly complex method. But basically what it is, it's the method by which we assign individual postal codes to a specific point in place. And it's not a simple matter, but we'll pretend it's a simple matter for this presentation. And the Geozones method essentially creates these threshold profiles of concentration, where we then get these gradients, areas where we have high concentration of high income or high concentration of low income. And we can get different concentrations of gradients for these different population subgroups. I'm not going to go into that one. I decided I'm not going to do that. So the methodology, which I'm going to describe, first I'm going to go through the methodology here and describe it a little bit in detail. I'm going to illustrate the methodology with examples. So I'll do like a slide describing it, and then I'll show you an example so we can look at it. And then I'm going to show 4 examples from research that we've done at StatsCan, or with researchers at StatsCan. The Geozones methodology is really a few different things provided together, and it's computationally very simple. You can do it in Excel if you really want to. You can do it in really whatever sort of software you want, because it just uses population counts and event counts. Those can be put in whatever software you want, and you do sort of a rank ordering method of it. So it's really quite easy. It's just, you can do it with calculation of proportions and then sorting. It's the basic threshold. So the first step is these calculation of what I'm going to call threshold tables, and that's directly drawn from the geographic literature. Threshold tables of segregation, where in geography they call it isolation or exposure. Here we're going to call it concentration or exposure. And then from that we can develop directly these things called concentration curves, and that will visually illustrate what this distribution of the population looks like over space. And from that we can then move into our quintile classification, so selecting quartiles, terciles, whatever we want, divided up into 3, 5, 7s, usually not much more than that. Or we can select a threshold. So we can select a cut point where we say anything with, below, with more than this percentage of a particular subgroup is called for example, an Aboriginal area, area of high percent Aboriginal peoples. So we can either do that. And then we can continue with our analysis of health outcomes once we have these binary areas, these different classified areas. There's some additional methods, particularly the concentration coverage curves, which are very useful in selecting these gradients and these cut points. So thresholds is essentially a table that shows where particular subgroups either form a majority, or the dominant group, or exceed defined concentrations. So these are calculated that for each population group, we calculate the proportion of a total population within a defined geographic area. So what's the proportion of people who are of high-income households who live in this area? And then, so if we get a high proportion of that, we can say that this area would be coded as a high-income neighborhood, right? So it's essentially concentration. So what we can say is proportion of people living in geographic areas with a given percentage of the same group. So 80% of this neighborhood, the population is from the highest income group. So we would say that's a very concentrated group, right? So it's very high concentrated. Whereas another area, there may only be 10% of people in the highest income group, but 40% of people in the lowest income group. So we would classify that one differently. And this can then be viewed in a table such as this, where the top portion of the table, I look at what we call concentration, or in this case, isolation. And what it is you have the percentage of the same group population of the total, in this case, dissemination area population. So on the in the rows, we have these different income quintiles, and in the columns, we have the proportion of each group where they have in the percentage of the same population. So if we look at the highlighted one here, which is the lowest income quintile, 10% of people in the lowest income quintile live in dissemination areas where there are between 0 and 10% of other people of low income. 3% live in dissemination areas where between 70 and 80% of the population are also in low income. If we go to the high Q5, high income, we see that, and it's the same as the Q1 lowest, 1% of people in the lowest and of the highest income quintile live in areas where between 80% and 90% of the population are also in low income. So it's saying that those neighborhoods have between 80 and 90% low income population. Those are very low income, it's nearly uniform low income areas. If we all digested that, that's one way of looking at it. So that's looking at sort of how concentrated people are, or in geography we would say how isolated they are. So there's only people of low income within it, or only people of, majority within high income. There are some which are only high income households within a particular dissemination area, so they're classified. It's just less than, a very small percentage. This is the percentage group exposed to the highest income quintile. We can also then look at, okay, well, what percentage of people in the lowest income quintile live in areas exposed to the highest income quintile? So now this is exposure. So we can say that people in the lowest income quintile, nobody lives in areas with more than 60%, or more than 60% of the population are of high income. Nobody in the lowest income quintile, at least according to this chart. There's probably a small percentage, but it's less than 0.01, right? Whereas in the fourth, so the second highest income quintiles, 1% live in areas where between 60 and 70% are of the highest income quintile. So they do have more exposure to people in the highest income quintile. So we can then look at how these two different groups interact spatially in terms of the residential segregation. This is illustrated perhaps more strongly with Aboriginal, looking at both all Aboriginal and bi-Aboriginal group, First Nations, Métis, and Inuit, in comparison to non-Aboriginal. So here we have two ends of the spectrum. So 38% of Aboriginal population live in areas where there are between 0 and 10% of other Aboriginal groups. So it's generally urban Aboriginals live in urban areas where there's a small percentage. Aboriginal as a total make up 4% of the Canadian population. So it's between 0 and 10%, right? But 26% of the Aboriginal population in Canada live in areas with more than 90%, where there are more than 90% Aboriginal. So these are, quite high, and we can look at that by different groups. 36% of First Nations live in areas where more than 90% are. 50% of Inuit live in areas where more than 90% of the population is Inuit. So we can really begin to look at it. Whereas only 17% of Inuit live in areas where between 0 and 10%. So we can really begin to look at it. And comparison for non-Aboriginal population, 95 live in areas, versus 4% in other areas. And we can name those cities. We can then take these tables and create what we call concentration curves. And this is essentially plotting each row of this threshold tables by its different column categories. And the curves can help visualize this exposure. I'm going to go over something called the concentration coverage curve, which is just a further extension of this, which can then be used to help define our gradients, but I'll go over that in a minute. Looking at income groups, this is the same data just represented on a chart, where I've plotted the 5 different income quintiles, where the light blue is the highest income quintile and the dark blue is the lowest income quintile. And these were the ones that exhibited the highest concentration or the highest isolation. And we can see that by the curve. We can see that the curve never peaks as high in sort of the middle range, and has a much longer tail going towards the right, where we can begin to see that more of those two groups live in areas with like groups. So they exhibit more tendencies towards living with other people in the lowest income quintile or in the highest income quintile. And this is the exact opposite from what we see from Aboriginal groups. So for income groups, we have this peaked or an upside down V distribution, sort of a more normal skewed curve, whereas with Aboriginal groups, we see a U-shaped curve. And this is, they're either very exposed or very concentrated, 2 ends of the spectrum. So on the one hand, we can see groups such as the Métis, where nearly 68% live in areas that have between 0 and 10% other Aboriginal or same group population. And very few live in areas that have, or is actually a 0 live in areas where there are more than 90% other Métis. By contrast, we can look at the Inuit, which is this purple line on it, and we can see that it was 17% in this 0 to 10 category, and it was 50% lived in areas with 90 to 100, with 90 to 100% other Inuit. So this is the end of the spectrum where we see what we would call segregation or isolation, and this other end, the left-hand side, is what we would call exposure. So these 2 ends of it, but this really provides a visual way of showing that. So the peaks are at either end, very few in the middle, and income groups were the opposite, where we generally see a larger mixing of the groups within this middle part, and few in the extremes at either end. Now that we've described our population and we've begun to see how the population is distributed in space, and we can say that these two socioeconomic and cultural identifiers work well for this. They exhibit different tendencies, but there are differences between these upper and lower groups. How do we define the groups? On the one hand, I defined by percentage of Aboriginal population. On the other hand, I did what we call these LICO quintiles, which is the 5 ranges of different groups. How do I then classify geographic areas, and how do I classify space and translate that into analysis of health outcomes? So do I want to divide it into 4 groups, so quartiles of income? Do I want quintiles or 5 groups, terciles? How best to do that? And if I'm classifying Aboriginal areas, and I want to say these are areas in Canada that have a high percent of Aboriginal population, what means high? Is it more than 20%? More than 80%? More than 90%? What is it? How do we define this? Is it just reserves? There are a lot of areas that aren't reserves that have 90% Aboriginal population. Are those not considered Aboriginal areas? Are they urban, rural? So there's lots of questions that we have. So we need some sort of method at defining these quantiles. So calculating quantiles is really easy, but your selection of it will influence the results and depends on the analytic model being used. So if we, and I'll illustrate that in our final example with terciles, if we use only 3 groups or 5 groups, the differences between the upper and lower group can be exaggerated or diminished. And it can depend by area. In the Aboriginal example, a high percentage of Aboriginal in Winnipeg means something different than a high percentage of Aboriginal in Montreal, right? There are a lot more Aboriginal peoples in Winnipeg. So it means different things. Same as income groups. The income and what it means to make $50,000 a year, for those of you who are students, that's only a dream, means different things in Montreal than it does in a rural community, right? So they have different meanings across it. I mean, certainly 50,000 in Vancouver trying to buy a house is not going to get you anywhere. Whereas in Miramichi, New Brunswick, it may get you somewhere. If you look at real estate prices, it's so cheap out east. It's crazy. So to calculate these, it's actually really simple. And I put this on there largely for reference, if people want to do it. Basically what we do is, by definition, each quantile contains an equal percentage of the subgroup under study. So the top group contains, you know, if it's a quartile, so top 25%, or quintiles, the top, you know, 20%, or terciles, the top 33.3333%, but an unequal number of geographic units. So there may be a small number of DAs, dissemination areas, or neighborhoods in the top group, but the same proportion of the total population. And the way you do this is you essentially just reverse rank the geographic areas by the population of the subgroup, calculate your cumulative percentage, and categorize it based on the breakpoints. So anything above, you know, below 20% and below is in the bottom quintile, 20 to 40 is in the next quintile, and you just essentially do that. And Excel, it's an if statement. It's really easy. So it's based on the percentage of the subgroup. Or you choose a cut point and you say, okay, anything above 33 goes up to this, and anything is down there. So it's, as I said, it's really easy to do. And what makes this method really powerful for presenting in a place like this is when we first tested this methodology, it was all done using the public use census data. So all data that can be obtained either through the DLI or in an RDC setting. So it can be calculated based on stuff that is publicly available. And it works just as well that way as it does using the census microdata in StatsCan. So the first example, and the longest example that I'm going to give you, partially because it was studied first and I've continued to study it quite a bit, is the Inuit areas. It's also a neat, clean definition. So it's really easy to, you know, perfect example to sort of study. Inuit-specific identifiers are not present on health administrative data uniformly. The territory of Nunavut has that registry, but other regions don't have that. Vital statistics and hospitalization. So calculating some of these core health indicators, we can't really get a handle on it. So prior to maybe 8 years ago, or we weren't able to tell you what's the life expectancy of the Inuit population in Canada. Well, we didn't know. We knew that there was higher mortality. You know, there's James Bay. There's all sorts of, you know, Davis Inlet was a big one. We know that these sort of things existing, but we couldn't really quantify it. And policymakers really like these quantifiable things, and people who deliver services really want things quantified. So one of the nice things about it is that the majority of Inuit, about 78% now, and going back even more, live in a fairly defined geographic area, what is now the Inuit Land Claims Area, or Inuit Nanangat, which is the Inuit homeland. So the Geozones methodology, in using this, provides a really good method which we can look at this population. And I'm going to show you how, first using a Geozones method, how we can identify the Inuit. And it actually just totally neatly corresponds with the land claims area, which makes the example really good. So looking at our population before, the same threshold table I showed you before, 50% of the Inuit population live in areas where there are between 90 to 100% other Inuit. So it's a largely an Inuit area. And this group in particular exhibits fairly strong concentration. They're concentrated in only a few different areas. So if I look at my 50% point, a large proportion of the population lives in areas where more than 50% of the population are of Inuit identity. Taking essentially what we had in the previous two tables where I divided up between 0 and 10s, I've now did it by quintiles, which is what you use for 20. I used Wikipedia to figure out that word. There's actually a page that tells you the words for each one of those, dividing it into 11 categories is this. So Wikipedia is great for that. And this shows the construction of I can't go up and touch the screen here because no one else can see it. So I'll use this. But if we have the quintiles on the very far left, going from 0 to 100, was this threshold quintile. Next column is the number of dissemination areas with the given proportion of Inuit identity. So at 0, we have all dissemination areas in Canada. In 2000, all populated dissemination areas in Canada. Then we have the cumulative number of DA with that particular identity, cumulative proportion of the population of Inuit, cumulative of the total Inuit population. So 2 columns here. So at the 1 mark, there are 3 dissemination areas where there are, it's between 95 and 100% Inuit is what it is. Cumulative proportion is 98% or 0.98 of the population is Inuit, but that's only 3% of the Inuit population. So when we're defining areas, we can say, okay, well, let's look at Inuit mortality. Let's select just these 3 areas because they're very, very Inuit. But it's only 3% of the Inuit population. So it's really not going to tell us much. It's not representative. And we can move up and we can say, I removed a whole bunch more. Let's select our threshold at 40, right? So 40%. Here we can see that at 40%, there's 50 dissemination areas, so quite a bit more, a much larger number of communities. 92% of the population in those 50 dissemination areas is of Inuit identity, and it contains 65% of the Inuit population. So that's actually much more representative. Now we've got 65% of the Inuit population, which we would be studying in these areas, 92% of whom self-identify as Inuit, so only 8% other. And incidentally, of that 8%, which is other, about 6% of that are other Aboriginal groups. So usually Dene, if we're talking about the Northwest Territories, or Inuk in the Northern Labrador. So when we're selecting our cut points, we can see then as we move up, well, if our cut point is 0.2, it gives us 121 dissemination areas, 58% proportion Inuit. That's getting lower. Step up 1 to 0.25, oh, that's 81% Inuit. We can see that's a sort of a clear dividing line between those two. And if we go to 30% and 35%, well, there's where our division lies between 90% Inuit versus 87%. So we can see a much stronger cut point. And now we're getting to 75% of the total Inuit population. So now we're getting a much clearer idea of who is the population under study. There's not a formula per se, but we can do what's called the concentration coverage curve, which my colleague who's here with me, Philippe Finesse, this is from his paper, directly lifted, available on the StatsCan website, which shows, which we can then plot these different relationships. And this is looking at 2 groups, the Inuit and the Métis, and looking at the possibility of how we can look at these 2 different Aboriginal groups. We can see from this, we can really begin to see sort of an inflection point. And I guess we could develop some method where we can begin to see the point where this, we could translate this into a smooth curve and find the exact point where it changes, right? But yeah, I think visually we can begin to see it. And in reality for the Inuit, there's a much better definition for it, and same as for Aboriginal. You can really begin to see where the cut point is. And it's sort of around here, right? Or begin to see it. And the Métis, we can find really, there's never really any amount of the Métis population which is within a concentrated area, which is concentrated. So looking at this group by an area-based method doesn't really work. The First Nations will get a very similar curve to the Inuit. Not quite as pronounced, but a very similar curve. Philippe, did you look at the First Nations when you did this? He said it's between the 2 curves, sort of between here, which is about what we would sort of expect. The another nice thing about this method is because we're dealing with areas, we can map them. And this is my background, and I like mapping things. If we set our threshold at 0.95, this is where we get this 3 communities, 3 dissemination areas. These are the 3 communities where there is more than 95% Inuit. And I'm just going to walk you through these different thresholds. And you can watch the threshold go down, our proportion Inuit goes down, and the proportion of the total Inuit population will go up. So we'll begin to see these, and you'll see more communities added on. And we begin to see, as we move down, which number of communities we're getting added onto it. We begin to see, okay, well, where are these communities? As we're getting down to a threshold of 0.5, it's now 94% of the population in these areas are of Inuit identity, 50% of the proportion of Inuit, obviously. Now right, it's just the inverse. So, but if we look at this, we're only including, 1 community within this, of the 4 Inuit land claims regions, only 1 community within the Inuvialuit settlement region, which is in the far west of the country. Most of Nunavik falls within that, and only 2 communities within Nunatsiavut, which is northern Labrador. And we begin to move down in our thresholds, and 0.35, 0.30, 0.25, we begin to see the addition of additional. If we go down to 0.20, we begin to see a few other communities added on. Way down in the very southeastern corner there, we see 3 communities which sit outside of the Inuit land claims area, or the traditional Inuit lands, but have a fairly high percentage of Inuit population. The neat thing about this is it fits very well within the traditional and the legislative definition of what an Inuit land claims area is. The Inuit land claims area, Inuit Nunangat, is composed of 4 regions, one of which is a territory. So northern Northwest Territories, the territory of Nunavut, northern Quebec, which is Nunavik, Nunatsiavut, which is northern Labrador. And this is the number of census subdivisions in the total population and the percent Inuit, which does vary between it. And it comes out on a map looking like this, which is the map of the Inuit communities, which we can identify via this Geozones method. And it fits very well. The only ones that have that could be sort of exceptions, the city of Inuvik has less than, it's between 30 and 35% Inuit. And there's a community down here, Happy Valley Goose Bay, which sits outside of the land claims area and has about 28% Inuit. So there are 2 that are sitting on the edge. Inuvik happens to be an administrative center for the Inuvialuit region, so it's considered an Inuit community. Happy Valley Goose Bay is not an administrative area. It's not considered an Inuit community, even though the large Inuit population. So that's just sort of the cultural definitions and where you blur the lines between these different things when you're dealing with Aboriginal populations, because it's a cultural definition as well as a geographic definition. So what can we do with this? Well, lo and behold, all of a sudden we can begin to look at some of these health indicators. We now have vital statistics which have the postal code. We can say, okay, well, these postal codes correspond to these areas. We can then look at life expectancy. Looking at life expectancy for residents of Inuit Nunangat, Inuit, other Aboriginal and non-Aboriginal population combined. This is just all residents of that area, compared to residents within the rest of Canada, because we can then select out all other areas. So we're excluding that population, even though it's very, very small. And we can look at these differences in life expectancy by males, females, and both sexes combined over time. In this chart, we can see that the dark green, or in the very far left bars, are 1991, and this is a 5-year aggregation, so life expectancy, it's all deaths that occurred between 1989 and 1993, so we pool over 5 years to get life expectancy values. That's why we have 4 periods corresponding with the census period. And we can see life expectancy, clear life expectancy differences between, for males, in 2006 was 68 years, compared with to 78 years for males in the rest of Canada. So clear differences in life expectancy. I don't know why that's a decline. Possibly because it's a very small population. And we've looked at this in a lot of different ways, and I've manually gone through the data to look and see if we got anything missing, but there does appear to be a decline. There was a large increase in, do I have by year here? No, I'll go back. A large increase in injury, particularly self-inflicted injury between that period. So it's where we began to see a higher number of suicides, essentially. And then there was also, surprisingly in that period, a decrease in the number of cardiovascular deaths, cardiovascular-related disease. I don't know why. I can't speak to the exact reasons for this, but as I said, I've manually gone through the data, as have multiple people, and we haven't really found a reason for that difference. There are some limitations to this in that vital statistics code, the postal code and the city name of your last place of usual residence. For people who have more chronic conditions and diseases, in the Inuit areas, usually healthcare is provided, at least in the older time periods, outside of the area. Until recently, there wasn't any primary trauma care facilities within the Inuit regions. Now there are 2 facilities in the area, but at the time there wasn't. So any serious injury, any heart attack or stroke, there was an automatic airlift to the south. People who need long-term care would generally receive long-term care in the south. So there may be some coding errors that, you know, if someone's been down south for a year in a long-term care facility, their usual place of residence may be changed to Winnipeg or Ottawa or Montreal, 3 large receiving centers, rather than being from the up north. So there are some limitations to it. But that being said, it would probably only serve to diminish the differences, right? Rather than exaggerate the differences. So we still see, and even though females have a higher life expectancy, the gap is still the same. And the gap goes between approximately 9 and 13 years difference over this time period. So a large differences. And it differs by disease. And here we can look at it for the 2006 time period. Total difference of 10 years for males, 9 years, 10.2 for males, 9.2 for females. And what contributes to that difference in life expectancy? Well, we can say that of that 10.2 years of difference for males, 1.5 years of that difference is due to cancer deaths, whereas 3.4 years of that difference for females is due to cancer deaths. So of the 9-year difference, almost 3.5 years of that difference are due to cancer. So it's cancers that are causing that, a large proportion of that difference. And if we actually look at it, smoking-related diseases, with smoking rates in the Inuit areas. For females, somewhere around 86%. So compared to 25% in the rest of Canada, very high. Whereas for males, we see intentional injuries. So this is an intentional self-harm, largely suicide. Homicide is also an intentional injury, but the homicide rate, deaths from homicide, is actually quite low. For males, over 3 years of the difference in life expectancy is due to intentional injuries. The second example I'm going to do is looking at high percent First Nations areas. And we have the same issue with First Nations areas as we do with the Inuit, in that we can't identify First Nations people directly from health administrative data. In some areas, they do collect that information, but it's usually it's not self-reported. It's usually reported by the provider. So does the nurse say the person is Aboriginal? Doesn't mean the person identifies as Aboriginal. They may identify as Aboriginal and not look it, because it's one of my facial appearances here, right? So some areas they do. If they have a band number, the health care will be reimbursed by the federal government, right? Because the health for status Indians is paid for by the federal government versus provincial government. So in those cases, there are some issues, but uniformly across the country, we can't look at First Nations people. So we can use the geozones to look at areas with a high percentage of First Nations people. Looking at our table here, we can say, looking at the high end of the spectrum, we can say, okay, well, we've got this 40% of First Nations population lives in areas where more than 80% of the population is of First Nations identity. We can map these. I'm going to go straight to the map here. And we can map them both within urban, across the country, so looking at dissemination areas. These are all the dots where within the highest Aboriginal quintile. So if we break it up into 4 different groups, this is where the highest quintile of the population sits. Largely rural. The lighter dots are rural. The darker dots are urban. And we can look at an urban center. We can look at it by dissemination area. We can map them by quintile. This is the Winnipeg urban area. We can see there's a concentration of dissemination areas within the top 2 highest Aboriginal quintiles, within the 4th and 5th quintiles. So these are areas that are of higher Aboriginal population, and we could then look at it in the urban context. But largely we're talking about urban areas when we're talking about this. So we're talking about a specific subpopulation of the First Nations group, not the urban First Nations in particular, even though it's a large portion of the population. But still, it's a start at looking at the health outcomes. This project in particular looks at the population aged 1 to 19. There have been a number of studies using record linkages approaches looking at First Nations adults. Our census mortality linkage links adults aged 25 and over. We have a First Nations identity on the census, so we can get that from there. But we can't look at children. So using a geozones approach, we can then look at First Nations areas, and we can look at mortality of children within high Aboriginal areas. So classifying using a 33% cut point is what I'm using here, into low Aboriginal identity areas and high percent First Nations identity areas. So this is comparing those areas that were within the highest First Nations and those that were in the lowest Aboriginal. So it doesn't include the Inuit areas, right? It's only areas that were low Aboriginal, all Aboriginal groups, including Inuit and Métis, compared to high First Nations. And we can see that in these areas, it's a total population of about 320,000. Not a huge percentage of the total First Nations population, but a large amount. And what was powerful for this study is we're looking at the age 1 to 19. We got of the population, nearly 95% of the population, age 1 to 19, was of First Nation identity. So very much looking at First Nations identity children and youth, which is what we really wanted to look for. Again, it's largely rural, 72% in there. And this is some of the, I also show some other characteristics that are different between these areas. Looking at mortality rates, then I'm just showing the mortality rate ratios. So the comparison of mortality rates between low Aboriginal and these high First Nations areas for the population age 1 to 19. Looking at injuries in particular, for females, the injury rate is 8.3 times higher in high percent Aboriginal areas, First Nations areas, versus low percent Aboriginal areas. For females, 5.3 times higher for males. The mortality rate for males is higher than for females, but the difference for females is greater. And that's also really important to be able to understand. We can be able to look at differences, not just individual rates. More sobering story, self-inflicted injuries or suicide. For females age 1 to 19, 22 times higher in high percent First Nations areas versus low percent Aboriginal areas. Those are very, very high numbers. Not surprising. We've seen these numbers in the media. We've seen these numbers elsewhere. But this gives us some real numbers and some real way of looking at these differences. The example 3 is income quintiles. This work was, a lot of it was done by Russell Wilkins at Statistics Canada. This is looking at some of his work which looks at neighborhood income quintiles. So looking at these 5 population groups, I showed you earlier, and this is the life expectancy differences between the highest income neighborhoods and the lowest income neighborhoods over time. So that we see for males in 1971, there was a 5.8-year difference in life expectancy between the lowest and highest income, whereas in 2001, there was a 4.4-year difference. And for females, a much lower difference in life expectancy between these areas. But we can really then begin to look at life expectancy, something as coarse as life expectancy, there was a difference in these different areas. More recently, they've looked at the age-standardized breast cancer incidence by neighborhood income. And this is looking at the women age 19 and older, per 1,000 women age 19 and older. And for those women diagnosed between the ages of 50 and 59, the differences between income quintiles over this time period. So we see that in general, those in the highest income quintile, there is a higher incident rate, and those in the lowest income quintile, there has been, in general, a lower incidence rate. And this is more pronounced in the older age groups, where there is a higher incident rate of breast cancer in the higher income groups than there is in the lower income groups. And this follows up from the literature. And it's slightly counterintuitive. Incidence is diagnosed as well. It's not mortality from. And there's a difference when you're talking about cancer, is that cancer, you have a diagnosis from the disease, and then you have mortality from the disease. And the rate differences in income between income groups can be different. I won't get into that here, though. That's a whole other area of studies. For female breast cancer, I don't know for income what the difference is. I believe that the mortality difference washes out, that the mortality rate remains similar, that there's higher diagnosis rates for females than there is for in the higher income categories than for females in the lower categories. For Aboriginals, we get this paradox where we get lower incidence rates of cancer, but we get higher mortality rates of cancer, particularly for males. And so it's this paradox of it, and it's because we don't have proper diagnosis, screening, or care. In theory. I shouldn't say that as from StatsCan, but in theory, because of this. So you have a higher mortality rate from the disease, but you have a lower incidence rate. So often these diseases aren't diagnosed until death. The fourth example I'm going to give is the foreign-born population, or immigrant terciles. And the reason I'm showing this is that this was a recent paper we did, and it really illustrates well the differences in selecting a tercile versus a quantile versus a quartile, etc. And looking at a population which isn't so clear, such a clear division as Aboriginal, non-Aboriginal, Inuit, non-Inuit. So if we look at the distribution of dissemination areas by percentage of foreign-born, we see that there's a small number of decreasing number of dissemination areas that have a small percentage of foreign-born, which are immigrants and permanent residents. And if we rank order them, by the percentage of the population in the dissemination area who are foreign-born, we get this sort of look, where we get this curve following up here. And if we compare it to the percent of the total foreign-born population who are in the DA, we get this curve here. So we can select our cut point in different ways. We can say that here we can base our threshold on the total national population. So this is the highest tercile, 66% of the accumulated population. If we say that 60%, 66, so the top 1/3 of the total national population, or the top 1/3 of the total foreign-born population, we get a totally different number of dissemination areas, and we get a different coverage of that population group. And this translates into here when we begin to look actually at health indicators. I just need to move this. where do we go here? The smart link thing. It's not so smart. It's sitting in my way. There, now we can read the bottom numbers. This is looking at hospitalization rates, which is this column sort of in the middle there. We see hospitalization rate. By these definitions, whether you define it by quintile or by tercile. And we can look at the differences in the hospitalization rate there. So we can see that in the lowest quintile of foreign-born, hospitalization rate of 840 per 100,000 versus 539 in the highest. So with lower hospitalization rates in areas with a high percentage of foreign-born. This is what we call the healthy immigrant effect, is what they often call it. They don't really know what the healthy immigrant effect is. That's why they call it that, because it's not a, they think immigrants are generally healthier population, so therefore it's, it shows up in these areas. And the difference in tercile, you see the rate ratios change, difference between 1.0 and 0.69 versus 1.0 and 0.64 by defining between tercile or by quintile, either 5 or by 3. But what we're really concerned about here is we're not, in studying the immigrant population, we would be less concerned about this middle group here. We're more concerned about the differences between the top two. And we begin to see that those differences are still evident when we use a tercile versus quintile, but we have a larger percent of the population, large proportion of the total foreign-born population within that group. So we're dealing with 2 million individuals versus 1.3 million individuals. 2.1 versus 1.3. So we're dealing with a larger population group of an understudy. And again, this changes then when we look at different areas. This is looking at all of Canada. If we then take just the population within the 7 largest CMAs in Canada, so Halifax, Montreal, Toronto, Hamilton, Winnipeg, Calgary, Vancouver, the largest 7 CMAs by foreign-born population, we can still see that difference, where we see the difference of 1 to 0.85 within those different areas. So some of the limitations of this, and it's also the first limitation I provide is also a benefit, in that the administrative data that we're talking about, so whether it's vital statistics, cancer incidents, or hospitalization, refer to all events occurring in a geographic area, not just the population subgroup that we're interested in. So there's a limitation in that we're not looking at just First Nations, not looking at just Inuit, we're looking at everyone who's lived in that area. But it's also a benefit, as I said, because services are provided generally by geographic area, particularly in terms of health services. That's what we're talking about. Hospitalization, well, hospitals all provide a certain area. There's really no way around it. So it's also a benefit in that we're studying everyone in that area, not just someone else. The population distributions, and particularly for income quintiles, often use the national population distribution. Although for foreign-born, this really comes out. So if we look at our foreign-born terciles, and we divide the total Canadian population, foreign-born Canadian population, up into terciles, where does that top 1/3 live? Not a lot of them live in St. John's, Newfoundland, if any of those dissemination. Actually, none of those dissemination areas, if we're looking at dissemination areas, are in St. John's, Newfoundland. Yet there are some areas in St. John's, Newfoundland that may be considered high immigrant neighborhoods. The meaning of what a high immigrant neighborhood there is different than in other parts of the city. Same as in Montreal, we have certain areas in Toronto and Vancouver, sort of, the big 3 areas, receiving areas of immigrants. Another limitation, and as I said, I'm not getting into this, postal codes, which are on these data and we use to link to the geographic areas, don't correspond to the standard statistical areas. So you can't say this is the particular point where a postal code is. Even though if you look at Google and you type in your postal code, it'll actually show an area. If you were then to overlay that over top of a dissemination area, the boundaries would not coincide at all. Someone could live in any of, so for 25% of the country, postal codes cover multiple statistical areas. sometimes, especially in rural areas, huge areas, very, very large areas. And so when we assign a geographic code to it, we are assigning it usually to just one place, right? We can't say they could potentially live in all these different areas. There are some methods that we have to do that. One of them is a piece of software which we call PCCF+. It's available in the RDC and via the DLI. And that's one way to get around it. There are other ways to get around it. Half of my research now is devoted just to geocoding postal codes, so I'm not going to get into it. The foundation for Geozones uses census data. There is some limitations in terms of coverage and under-enumeration, particularly for the Aboriginal population. There are some reserves that are under-enumerated or not enumerated at all. So they're not represented in the census. There are some ways of getting around that, and we have gotten around it, because essentially if a reserve doesn't participate in the census, we can call it a Aboriginal community. So the events are still recorded, right? Hospitalization events are still recorded to that area. Deaths still occur in that area and are still recorded. We just don't know the exact population distribution within that area, but we can estimate that from other sources as well. And that over time, there's been changes in the meaning of Aboriginal self-identity. So for the Aboriginal group in particular, what it means to be Aboriginal and how the question has been asked, whether it's, are you of Aboriginal ancestry? Do you self-identify as an Aboriginal person? That has completely different meanings, and there's a change in the reporting of Aboriginal self-identity. And there's been demographers have done a lot of great research on this, on the growth of the Aboriginal population, particularly the Métis population. The growth of the Métis population in Canada is such that it's impossible to have been by just fertility alone. It's a change in identity, right? It's a growth by like 70% growth in the population, which is just not possible. But demographers, went and figured it out, what it is. And it's a changing, and it's a growth of what it means to be Métis. So a lot of more people are either realizing or admitting that they're Métis, depending on what it means. So this is essentially the end of my talk. As I said, one of the benefits of this method is that it is something that's available to researchers outside of StatsCan. It doesn't rely on microdata linkages, or special data access agreements. It's all stuff that can be done for researchers within your existing data agreements, providing you can get the numerators, which are the hospitalization and vital statistics, which I understand you guys can get through INSPQ. And you can also get 6-digit postal codes within Quebec. So, which 3-digit postal codes are a little bit harder to work with. I want to acknowledge the work of other researchers in developing this methodology. Russell Wilkins as well, my colleague who is here, Philippe Finesse, who's done work as Gisèle Carrière, who was co-author on the paper. As well, some researchers at the Aboriginal Affairs, and of course, a lot of this is done by provincial and territory vital statistics registrars and Canadian Institute for Health Information. It's not that who provided the hospitalization data. I also have my contact information here and a reference list of papers that I referenced during the talk. So this PDF, I hope, will be made available. The PowerPoint presentation will be made available to people. If not, anyone can email me and get it. It's public. I can get it translated for you if you would like to. My apologies that I couldn't do it ahead of time. I have some of it translated already. The article it's based on is available in English and French. So if we have any questions from the gallery,